พี่สวัสดีครับ
ดีค่ะพี่จะเรคคอร์ดวิดีโอให้เขา
โอเคอ่า
ค่ะ
เดี๋ยวผมมีปัญหาเพราะว่าไอ้ที่ผมนั่งอยู่มันมีไฟอยู่ข้างหลังใช่ไหม
ใช่ใช่ใช่
เดี๋ยวไม่งั้นต้องย้ายไปนั่งที่อื่นเดี๋ยวหาที่
จ้ะ
นั่ง
จ้ะจ้ะโอเค
ไม่ได้
เดี๋ยวพี่
เลยมุมไหนก็มีไฟ
ใช่ใช่ไฟมันแรงมากเลยหมอ
อืม
จ้ะจ้ะ
เหมือนจะดีขึ้นหน่อยหนึ่งครับผมเลยปิด
ที่จะมาเลยสองคนนั้นรู้จักนะ
อ่าใช่ครับรู้จักมาร์ติอัสครับผมแต่ว่าอีกคนหนึ่งเป็นเพดิเอติกยังสตาฟเหมือนไม่แน่ใจแต่เขาเป็นถึงชีฟ
นั่น
เขาอาจจะนั่นนะแต่ว่าคนที่จะมาโนเวมเบอร์กับดรกวงนั่นคืออดีตชีฟของหน่วยนั้นนะครับผมซึ่งผมอาจจะรู้จักคนนั้นเพราะว่าเมื่อตอนที่ผมอยู่เขาเป็นชีฟคนนี้อาจจะเป็นกับดรมาซิอาสเป็นไอตอนนั้นที่เรา แซวกันคือตอนที่เราเริ่มเซตไอตรวจ NGS ใหม่เนี่ยดรมาซิอาสนี่คือเป็นอะไรมาเจาะเลือดส่งเซกเวนหมดครับ
เป็นโอกาสดูแบบตรงนั้นเนี่ย
อ่าดูแล้วครับผมแต่ว่าเดี๋ยวต้องคืออาจารย์คิดว่าเราแก้เป็นแบบให้มัน subjective แล้วเราน้อยๆหัวข้อแล้วเราใช้ judgment ใช่ไหม
อันนี้ถ้า
ครับ
คิดว่าจะสัมภาษณ์หนึ่งคนแล้วเราจะดูประเด็นอะไร
ครับ
ต้องอย่าง
ตกลงเปลี่ยนมุมหาที่ไฟดับไม่ได้ผมก็เลยต้องปิดไฟไปเลยครับพี่นิกกี้
Morning, Dr. Brian and Dr. Mandy.
Good morning.
Hi, Leah. Justin is not here today, right? It's you, right?
No, Justin's going to join in a minute, but he's still on another phone call, so I'm just starting the call.
Okay. Should we wait for him to join, or you can start the introduction for the speaker?
It might be better if we wait for him to join, and or is Liana on the call yet?
I haven't seen her name yet. Only two speakers joining.
Well, then maybe sorry, we have two calls going here and neither one of us like have our headsets on. So maybe it would be best then if we want to get started. Brian, do you want to do your own introductions?
That's fine. I think Mandy and I are in the same building. She's like 3 floors down or 4 floors down. So
Okay, perfect. So Brian, we'll start with you, and then Mandy, maybe you can do your intro as well.
sure, yeah. So
Perfect.
I'm Dr. Brian Brinkerhoff. Hi, Liana. I'm a GI pathologist at Oregon Health and Science University. I've been here since 2019. I've practiced in Canada for a couple of years as well. So we have a team of 5 GI pathologists and 2 pathology services that we run here.
Excellent. Thank you so much, Brian. And Mandy, would you mind giving us a quick intro on who you are and what you do?
Sure, I'm Mandy Van Sant. I'm a pathologist that works alongside Brian here at OHSU. I'm on the GI pathology team. I also am involved in the blood bank operations on the clinical pathology side. And we both actually wear some education hats with our residency program as well. And I want to make sure we introduce Dr. Tubb. He's going to also present today as well. Or maybe he's known, I'm not sure.
Dr. Tubb is famous amongst all of us. Hi, Tubbs.
No. Hello, Leah. Hi, I'm Dr. Thong Tham Anepurishanang. I'm the molecular pathologist at Sirat Hospital. I was at OSSU in 2018 to 2020 at the Night Cancer Institute. Hello.
Thank you very much, all 3 speakers. We are at
Doctor,
UMH.
you have the Liana, right? Dr. Liana. Yes.
Yeah. Prof. Lena, I have seen you join already. Thanks once again for the interesting lectures today. BDMS, colorectal and GI cancer team, including pathologists, are in the call right now and enthusiastic to hear the talk today. Thank you.
Liana, did you want to say any words before we go into the presentations?
No necessary. Thank you, Brian. Thank you, Sandy, for being here today. I really appreciate it, and I'm looking forward to the lecture. So we'll
Perfect.
get started. Yeah,
we'll get started.
We were asked to talk a bit about the synoptics reporting in colorectal cancer and what you guys should be looking for. So we divided our talk into 3 parts. So Brian's going to talk about some of the diagnostic challenges and review some of the maybe a specific parts of cases that we find challenging on the pathology side. I'm going to review kind of that in-between piece on how at OHSU we've developed workflows to identify more and more patients for certain testing and how we communicate that within our reports. And I'll show you some of our templates and things. And then we're going to hand it to Dr. Tubb to go over some of the molecular portions of colorectal cancer and communicating those molecular findings. So Brian, I'll hand it to you to go first.
Okay. Can you see my screen? And let's see, more specifically,
Yes.
If I do that, does that look okay? Is that presentation mode?
Can you put full screen? This one looks presenter view.
Let's see. How do you do? Uh-oh. No. I don't know. Mandy, are you an expert? I can go like this. It's just a little less professional. Is that okay?
yeah, that is good. And if you go up to slideshow
Yes.
and hit that and go from beginning. So, and then go to display settings and choose the other one. You're right now,
There we go.
there
Right?
you go, yes.
Okay, thank you. Sorry. Thanks for your help. I'm really grateful to connect with all of you, and thanks for waking up early for this. We're about to head out of the office, so it's just kind of fun to be in different areas. I wanted to focus more specifically on malignant polyps, and I tend to be a little soft-spoken, so tell me if I need to speak up. I'll do my best. But I recognize as a pathologist, our language is kind of funny, and it makes your eyes glaze over. So I'll do my best to kind of describe what I'm showing here and hope it is relevant to everybody. But feel free to interrupt if there's any questions. So when we talk about an adenoma of the colon, we're usually describing low-grade dysplasia, shown here, where there's a distinct difference of the cells. When we talk about high-grade dysplasia, we're talking about both architectural complexity and cytologic, the cells are pleomorphic and they're jumbled. So we can see that in a polyp. Another term that comes up is intramucosal carcinoma. And that's a bit of a confusing one that I avoid. But technically speaking, it's when you have single cancer cells in the mucosa invading the lamina propria. The reason it's controversial is because these patients don't have much of a risk of lymph node metastasis. And so I tend to try to lump these with high-grade dysplasia, but you might see pathology reports that talk about intramucosal carcinoma. And that is, by definition, a pretty low-risk finding in the colon. In the upper GI tract, that's not the case. And the reason for that is the lack of lymphatic channels in the mucosa of the colon. Okay. So to progress to cancer, we use the word invasive, at least at our institution, to mean that it's going at least into the submucosa. And the best histologic marker of that is desmoplastic stroma. And that's shown here where you get this swirling gray-pink stroma that surrounds the glands and is induced when there's breach of the muscularis mucosal layer. So if it's just confined to the mucosa, you don't see desmoplasia like this. So in our group, we're sometimes comparing and seeing, do we agree that there's desmoplasia or not? By the AJCC cancer staging guidelines that we use in the United States, the T stage is determined by the depth of invasion. So T1 lesions are the ones that we see in malignant polyps, whereas you would not see T2 through T4. So here's a low power view of a malignant polyp that arises from a background adenoma. And T1, by definition, is below this muscularis mucosal layer. So you can see it invading down, you can see desmoplasia, and you can see that the tumor stops before you get to the stalk. This is a pretty common finding in colonic adenomas for us. I don't know if it's quite 11%, but we see it with some regularity. And importantly, these polyps are cured if they're endoscopically removed, if the specimen integrity is maintained, and if there's no unfavorable histologic features, which we'll talk about in a moment. So this is more of a clinical algorithm for concerning polyps. And if, as I mentioned, if there's any high-grade dysplasia in these polyps or any malignancy without anything concerning histologically, so favorable histologic features, then follow-up, conservative follow-up is adequate. But in contrast, if there's a lack of complete endoscopic resection or something unfavorable about the histology, then a more aggressive surgical approach is usually the next step. So we spend a lot of time in pathology focusing on this favorable histology part. And one pitfall that can mimic malignant polyps is misplaced epithelium. This is a live case of one of my colleagues who shared this just yesterday. And you see glands that are down in what looks like the submucosa. However, the architecture of the glands is pretty lobulated, rounded, as shown here. The glands are also surrounded by lamina propria, just like you would see up in the mucosa. So these inflammatory cells that are cuffing this are a clue. And there's also pretty commonly some form of hemorrhage or hemosiderin shown with the pigmented area, which is seen whenever there's trauma of a polyp, pedunculated polyps specifically. Another feature that is reassuring is that these glands are, although dysplastic, so they're blue, but they're low grade. So if these glands were to be high grade, I would be more worried, but this is reassuring. And finally, there's no desmoplastic stroma. So all of these features help reassure me that I'm not dealing with a malignant polyp. So we also spend some time just distinguishing those two. So CAP synoptic reporting is a lot of information. I've focused on the protocol related to excisional biopsies or polypectomies of malignant polyps. And all of the features on the left are required. First of all, we use the AJCC 8th edition for the T staging, TNM staging. We report the tumor site, the histologic type, the grade, the depth, the extent of invasion. So T1 would be into submucosa, lymphovascular invasion, the margin status, particularly the deep margin, and the status of the non-invasive tumor or adenoma to margin. Optionally, you can report tumor budding, which I'll show an example of. You can mention what type of polyp it arose from. You can mention whether it's pedunculated or sessile. And you can mention if there's any background colitis, for example, if it's in the setting of inflammatory bowel disease. So I've bolded the features that are high risk by the literature. And the tumor budding score is becoming more and more adopted and ingrained, and I don't think it'll be optional for much longer, at least in the United States. So if the tumor histology is poorly differentiated, so it's not, that means that it's more solid looking or not recapitulating normal glandular architecture, that's concerning. Lymphovascular invasion is concerning. If there's tumor within 1 or 2 millimeters, depending on the study you look at, that's concerning at the deep resection margin. Or if the margin cannot be assessed, that's a high risk feature. If there's high grade tumor budding, so you have more than 5 tumor buds at the invasive front of the tumor, or another criteria that's increasingly talked about is the depth of invasion into the submucosa. So is it just superficially invading or is it deeper than that? So any one of these would constitute a high risk malignant polyp. And I'll show examples of each of these. The rate of lymph node metastasis is very low for malignant polyps that are low risk in terms of their histology. So it might be 1%. Of course, there are those cases that are 1% false negatives where the tumor progresses. But for the most part, these are managed by conservative endoscopic mucosal resection. Whereas if you have at least one unfavorable histologic feature, by some reports you can have over 30% risk of local or regional lymph node metastasis. So that's quite high. And so surgery is often warranted. Although I'm sure you've dealt with this before as we do, and there's a lot of borderline cases where patient preferences and the clinical setting is discussed in addition to our uncertainty on the pathology side. So it's not always cut and dry. So by definition, poor tumor differentiation is when you have a lack of glandular formation in over half of the tumor cells. So this is an example from this study of poorly differentiated adenocarcinoma, not making glands. Lymphovascular invasion is quite challenging for us as pathologists. There is a lot of artifacts in the tissue that can confuse us and mimic lymphovascular invasion. This is an actual example in the middle here, where you have a focus of tumor within a lymphatic space. It's away from the leading front of the tumor, and it's adherent to the endothelial layer. So this is small vessel invasion. Here's an example of large venous invasion. The margin can be difficult due to cautery, shown here. So here's invasive carcinoma that is then obscured by inflammation and cautery. So it's really hard for us to tell. This is an example of a really nicely oriented malignant polyp with inked deep margin and tumor that's clearly with, you know, a millimeter or so away, so we can measure that. If the tumor distance to margin is less than a millimeter, the risk of recurrence locally can be, you know, over 20%. But that drastically drops off if you can clear the deep margin by even 1 millimeter. So this is an example of tumor budding where you have infiltrative carcinoma with single cells or small clusters of cells, quite a few of them within this high power field. So this would be probably a intermediate to high score of tumor budding. I would say high scores as you're looking at this. This is a challenging thing for pathologists to assess because of the background inflammatory changes that we deal with. So I'll just mention in brief different classifications for invasion into malignant polyps. The Haggett classification is talked about whenever there's a pedunculated polyp, and the only risky level of invasion is if it goes below this muscular mucosal line of the normal bowel wall. This is a level 4, which has a much higher risk of lymph node metastasis. But if it's just going into the stalk or the neck or the head, that's less concerning. The Kikuchi classification is for sessile polyps, and by that system, there is an SM1 depth if it's just superficially invading, all the way down to SM3 if it's deep into the submucosa. So the problem with this method is that oftentimes they don't come so well oriented, and we don't have the entire submucosa to evaluate. So a workaround has been to measure the depth of invasion from the muscular mucosal layer. But this also has a lot of problems, as shown by this article, which I will end on. So 6 GI pathologists at 5 different academic centers independently measured 52 malignant polyp cases. And in the first round, they followed the guidelines as they understood them. In the second round, they followed the guidelines per consensus meeting that they held to see if there was better agreement. And they measured from different points, both from the muscularis mucosa, from the surface down to the deepest part of the tumor, and then a hybrid of whichever made the most sense. So in round 1, these are cases that were deemed to be less than 1,000 micrometers of depth. And these 6 pathologists had all sorts of different numbers of cases that they felt were in that category. And so the correlation coefficient was quite poor in that first round. In the second round, it improved, particularly if you're measuring from the surface. But the typical measuring from the muscularis was quite poor. So you can see a whole range from 3 cases up to 15 cases that they thought were less than 1,000 micrometers. And that's using their best judgment. So we have a long ways to go with how we measure. And it's just to raise awareness that it's challenging for pathologists to be consistent with this topic. This is the same tumor with 2 different best guess measurements by 2 different pathologists. Same thing on this level and same thing on this level. So the distance can be quite variable depending on the condition of the polyp and the interpretation by the pathologist. We do show these around and try to have agreement, but again, issues to resolve are listed here. So last slide is just to mention that tissue integrity is important. And so sometimes if the polyps are sessile, you can pin them out, and that'll help you assess the depth and other factors a lot better, including the margin status. So anytime we deal with fragmentation, cautery, folded tissues, or superficial sampling, we run into issues of deciding whether there are high-risk features in malignant polyps. So these are my references. That's all I have for my first part. Are there any questions before we go on to Mandy?
อาจารย์ไพโรจน์ any question from you ไหมคะ
No, very informative for me, especially for the how we measure the depth of the invasion. Thank you so much.
You're welcome. Yeah, thank you.
We can go ahead to the second speaker and can do the wrap up question later.
Okay.
Okay, I found my mute button. How is the view on mine now if I do full screen?
Yes, thank you.
Good. Yes, you're welcome. So Brian did such a great job of outlining some of the diagnostic challenges in pathology that we talk about internally a lot. And then what I really wanted to focus on is how we translate those diagnostic challenges into our pathology reports, which is our main source of communication for all of the clinical teams, of course, so that you guys know what to look for and where to find it. And I just want to walk you a little bit through the OHSU experience and how we have addressed quality of our reports and standardization. So Brian mentioned briefly that we do have a team of people working on all of the colorectal and GI cases. So it's 5 pathologists. We have 1 year-long pathology fellow, 12 residents, 3 medical student fellows, and then 5 pathologist assistants. And any of these people or all of these people could be involved in our reporting at some point, either through the gross examination or through the microscopic examination. So we really wanted to develop a system, a quality system for our team that created standard results for you, even in the face of diagnostic challenges as best as we can. So our first step in this process was to create as much standardization in our reporting as we could. So we created our first step about 5 years ago was when our department switched from what we call a general sign out, where every pathologist signed out every type of organ system, to a subspecialty model where we have just GI team signing out GI cases. And one of our first quality improvement steps was to take a look at the gross examination of the tissue and our processes there. And what we found is that there was a lot of variability between experience levels, between medical students doing this grossing and pathologist assistants who are master's degree trained, creating these reports. And we found that if we created templates, that could improve our consistency. And what we decided to do was focus on benign templating, being more in a paragraph form that read nicely, was fast to dictate, which was important to keep up gross room efficiency. But for our malignant cases, we really opted for a table format. It's a little more time consuming for our grossers to put that information in, but I'll show you how that helped standardize our reports. So this is our right hemicolectomy gross template. There's a lot of wild card symbols in here that are what we opt for the grossers to fill in. So they can insert the label, they do a clinical chart review to look for preoperative therapy, whether or not that was performed. The procedure type, they chose this template because it was for a right hemicolectomy. And as you go through, you can see that when pathologists need to find this information, when we're reviewing the slides, we know where to look each time. And I think that's hopefully true then for our reports when it goes to the clinical teams. If they're trying to gather data for a large study, or maybe just look at their individual patient, those items should be present in the same areas at the same time. As we improved upon these templates in an iterative pattern, we also added things like the fixation details as we started to do more HER2 testing, so that ischemic and formalin fixation time would be able to be found and recorded. Whether or not we knew exactly what the guideline was always going to be for that testing, we could document those times and have them present for the permanent record, because figuring out that in hindsight can be quite difficult on the pathology side. So next is an example of a LAR case where it's filled in, and you can see that the length didn't change that much after we inserted the actual information. And even between the two reports, the right hemicolectomy and the LAR, the information is still presented in an organized manner. Additionally, what is within this template is we went through the synoptics that we're required to use for reporting and made sure all of those elements that were pertinent to the gross exam were present and in line with how those reports went. So it's, again, another improvement on our efficiency during this process. Our laboratory information system that we use is Epic Beaker, and they have the CIP Synoptics built into those templates. So this is an image from the website, but all of those malignant cases will have a CIP Synoptic built into them. And because those come from a big company, they tend to be very standardized, and we haven't done much editing or improvements on those on our own. But similar to the gross templates, these are templates that we fill in the same order all of the time. One of the big differences about these particular synoptics compared to the gross ones is the synoptics are searchable in a discrete manner, which is a little bit better for long-term data collection if needed. Another great thing about these synoptics is there's computer stops built in to make sure the pathologist has filled out all of the required elements before finalizing the case. So after thinking about report standardization as an improvement to our pathology processes on the GI team, we also have put a lot of effort into finding the best ways to complete consensus. So probably our most recent improvement has been to go to a twice-weekly conference where all of our team who's on GI at that time gathers together and brings their challenging cases to share with each other. We're able to do this in a virtual format. We have cameras on our microscopes, and we can share those cases individually. We've also allowed time to discuss larger topics when they come up, like reporting of appendiceal neoplasms and what language are we using, and we use that time to find standardized language and to check each other. We show each other cases and one-on-one quite often to find consensus as well in between those twice-weekly conferences. And then we rotate who performs tumor board, and that gives us a great quality review on each other's cases as we prepare. So there is one for GI oncology, but we cover about 5 conferences a week as a team. Another type of review that we perform that helps us build consensus is when in our MMR and HER2 workflows, it's often a second pathologist that receives those slides because they'll come out a day or 2 later. It may be the same pathologist, it may be a different one, but when we get those slides, it allows us to review each other's work, and we look at reports and helps us align our language and our thresholds for certain cases as we do those reviews. And then finally, our collaboration with the Knight Diagnostic Laboratory for molecular cases. We're very close in our working relationship with that laboratory. And so as needed, we can collaborate with them on unique molecular findings. So those are our key points for establishing internal consensus with our team. And we also have policies and procedures for evaluating external consensus. So we are a large academic hospital, and we get a lot of patients coming from around the state and around the region to receive care at OHSU. And there's a policy here that the pathology and radiology is reviewed before surgical procedures or beginning chemotherapy. So those slides come to our team from all hospitals in surrounding areas, and we perform those reviews and agreement. And our agreement rate is actually very high. It's not very often that we find major discrepancies with outside institutions, sometimes minor discrepancies. And probably the most common in the area of colorectal cancer is reporting on those optional characteristics in malignant cases like tumor budding or LVI that other pathologists have not reported on, but we know that's important to our clinical teams here and to our standardization, so we'll tend to report on those even if they weren't on the outside pathology reports. We also receive true consults, so that's pathologists at other areas asking us questions, and when those come through, we tend to review them in our group and sometimes chat with those pathologists about their review. And then we also invite those pathologists that are sending us consults or work with us closely, like at the Veterans Hospital or at Hillsborough, to join our consensus conferences when they're free, so that hopefully our outreach and can be with those groups that we work with closely to spread some of the information. We review pediatric pathology cases, and we have some subspecialists in our department to help us in certain instances, certain pediatric cases. We can get their expertise. And then one of the last areas of pathology consensus that we do externally is we participate in certain forms of proficiency testing through CAP. And a great example of that is our HER2 testing, where those unknown slides are coming to us from the larger pathology, College of American Pathology. We review those unknowns and submit our answers and wait for the results. And that helps us make sure we're maintaining a high quality standard as well. So the last form of consensus that we've put a lot of thought into is how we correlate clinically. And our main mission on the pathology side is to be available for questions and to talk when there's issues that arise. And we do that primarily through tumor boards on individual cases and other conferences. We run some teaching conferences. There's a liver conference, so that we're always exchanging information when we can with the clinical teams. And one simple solution was to create a group email so that we're easily accessible and you don't have to realize who's working that day or not. You can shoot us an email and we can always talk clinically. So my last topic on how we can communicate these important findings to the clinical team and what we've done on the pathology side to improve our communication was really working on our ancillary testing workflows. So there's a few regulatory challenges in this arena that we face here in the US. There's something called the No Surprise Billing Act, which is new, and I'll go over in a second. Recognizing some of the challenges in diagnostic test ordering versus reflex testing on ancillary topics, and I'll show you what our actual reflex testing policy is here. So essentially, the No Surprises Act is a federal law that was enacted in the United States to protect patients from unexpected medical bills in situations like out-of-care network, and it includes laboratory testing. And so there's some laws in place that we need to follow. And for laboratory testing, we need to think about how these are billed and how these are the opportunity for billing might be communicated to the patient. So on the pathology side, the best we can do is be quite transparent with what our policies are for testing. And we'll go to the next one to further explain that. Reflex testing is very important in colorectal cancer, as with other GI cancers that we see. And it is this area that can get a little tricky with the way the laws are written. So if there's diagnostic testing that we need to perform in order to make a correct diagnosis, pathologists are able to go ahead with that testing without approval from anybody else. Reflex testing, like for molecular testing, is specifically, there needs to be a policy in place that can guide the work that we do. This is an example, long story short, this is an example from a different type of cancer, so non-small cell lung cancer, on the benefits. I'm going to highlight the benefits of creating a reflex testing policy. So really, there's a lot of therapeutic implications that can come from this type of molecular testing. And so standardizing a workflow to decrease the amount of time it takes between making the diagnosis, somebody recognizing that diagnosis and ordering the next reflex testing, we'd like to decrease that amount of time. And you can do that by policy, and pathologists can play a pretty critical role in being those, adhering to that policy, and being the one that orders those tests rather than waiting for the order to come back, and then we have to pull the case, review it, and order that testing. It must be governed by a protocol that's defined by the multidisciplinary team, and that's what we did in our case. We drew a team of some of the clinical clinicians, surgeons, pathologists, and molecular pathologists together to create a policy that was collaborative, that improved the turnaround times, and that helped identify as many patients as possible that needed this testing to go ahead and get it. So in our case, this is what our policy looks like. Just to highlight the specific points from this talk, there is the MMR testing ordered here for adenocarcinoma of the colon and rectum. And then the Gene Trails Comprehensive Solid Tumor Panel is ordered, which is our molecular panel on metastatic sites. In-house only, so not on those slide reviews that we're receiving from outside facilities, but in-house cases, we can go ahead as pathologists, reflexively order those tests and report them, and we've really shown that that's a benefit to how quickly that information can get in the hands of clinicians and patients. So again, our workflow for the MMR testing is making sure we're communicating clearly in our reports if there's enough tissue to perform this testing. It's often reviewed by a second pathologist, and we found that the immunostains are quite a bit faster in turnaround times than the molecular testing, so we go ahead and do the immunostains on every colorectal cancer case to get the information out within days, whereas the molecular testing here would take a few weeks. We have a template, again, back to the template concept, to communicate what our results are. So it should look the same every time to the clinical teams receiving that information. HER2 testing is becoming more and more commonly requested in colorectal cancers. We use the Heracles trial guides for our interpretation. We did a temporary trial using the dual-ish HER2 testing, but we've decided now that our best option is to reflex equivocal cases for FISH testing. And just to review the study of our interpretation, it was in Modern Pathology in 2015, and it created, excuse me, it communicated a HER2 scoring system specifically for colorectal cancer that we incorporated into our guidelines. And so there are examples here of what no staining, 1+, 2+, and 3+ staining should look like in colorectal cancer. So we didn't have to borrow from breast cancer guidelines or the esophageal guidelines for this interpretation. Instead, we base our reporting on this study. And again, we have a template that communicates what our results were and what criteria we were using to score those HER2 cases so that it looks the same each time to the clinical teams. Okay, I hope I've been able to highlight some of the quality improvements that we've done as pathologists to make sure that when you receive information on our synoptic reporting and on our cases that it's clear and that we're available to help work through and talk about any of the issues that come up. Happy to take questions or hand it off to Dr. Tubb.
Thank you. Can we move to Dr. Thap and ask everything at the end?
Sounds good.
อาจารย์ตูมทำเชิญเลยค่ะ
ขอบคุณครับ thank you okay give me a second okay so after Brian and Mandy I will talk about the essential molecular pathology okay so the molecular pathology has two essential parts. A part is that involve the clinical, right? The clinical management of the patient. And another part is the science and technical issue, how to do the test. So definitely I will focus on the clinical side. However, some of the understanding limitation and something like that, it will be based on some basic science and some technical issues. So I will touch some of those when necessary, but this talk will be focusing on the clinical use of the molecular pathology. And if in the future you want to have some in-depth detail on the technical or on the scientific background, then I'm happy to arrange that for you. Okay, so I have nothing to disclose. I have been with the OSSU for 3 years doing the MGP fellowship. So I'm familiar with the OSSU system. So my talk will be my opinion because right now I'm familiar with the system there anymore. Okay, so the goal for the molecular diagnostic assay request is that we want to provide the correct diagnosis. Give me a minute. Sorry.
Yes, we hear you, but we lost the
Sorry,
slide.
I have an issue with the must be this one. Okay, so the goal for molecular diagnostic assay is to provide the diagnostic, give you the therapeutic option, and give you the prognosis, right? That's the main clinical goal for this one. However, most of the molecular tests will have the overlap utility for this purpose. And in the colorectal cancer, I think we can summarize that the main goal is 3 of these. Is that we want to identify the familial case, right? The case that has the tumor inherited syndrome. In that case, we can help reduce the risk of the family at risk. The second goal for the clinician is that to identify the specific mutations for targeted therapy. And the last one that has again a lot of use right now is that to look at the genomic or transcriptomic landscape for immunotherapy. The specific mutations, you can have the classic alteration, right? When you have the colorectal cancer, the classic one, you have the APC loss of function, KRAS activation that has implication on the anti-EGFR therapy. Or in some case, you want to find the rare alteration. For instance, the HER2 that Dr. Mandy just mentioned is not common, but if you found it, it has the therapeutic implication in the metastatic disease. For the genomic transcriptomic landscape, right now, I think we are focusing on the MSI and the tumor mutation burden. Okay, so first I will talk about to identify the familial case. We know that colorectal cancer can be a part of the familial cancer syndrome, and 2 of them that everyone know, I believe everyone know about these 2, right? Is the Lynch HNPCC and the familial adenomatous polyposis, because these 2 have a very high penetrance of the colorectal carcinoma, and it's quite common in the population. You can have around up to 3%, depending on the population of the patient. So another gene are the less common, but some of the gene has a very strong cancer predilection. For instance, if you have the inherited POE or POD polymerase enzyme, right? This is the proof reading defect. Patient will also have a polyposis and have a high risk of the cancer in the future, but these are rare compared to the first 2. And the other one for the GI colorectal clinician will be aware of the juvenile polyposis, point checker, Cowden, and Lee-Fromen-Eye syndrome. These are not as common, but some of them have a very strong cancer penetrance, like the juvenile polyposis and point checker. So if we identify this one, it has a very strong clinical implication. So at OSSU, they just published the large scale, the Healthy Oregon project, right? They screen the healthy people, the volunteer. They just distribute the box with the DNA sampling kit, and then they ask them to return it, and we do the complete sequencing and focusing on the cancer predisposition gene. So, and it's quite a lot from the data. In the colorectal world, we focusing on this one, right? The APC1, the MMR gene. Okay, but most of the gene that we identify are in the ATM, BRCA1, BRCA2, and LDLR. So those are the breast cancer one. But in the colorectal world, we also have a lot of the cancer predisposition syndrome. So from this data, we identify around 5% pathogenic or likely pathogenic variant in population. This is the healthy population, unselected, we just the volunteer one, right? And not the proband yet. These people don't have the cancer yet, but we identify the pathogenic in the cancer predisposition gene. In the colorectal context, it has around 0.4% for the Lynch associated variant. So, but combined of them together might be around 0.5 or 0.6. So, in some research rich country, it start to have utilization is that we screen every new cancer case for the cancer predisposition syndrome, because in the population you can have as high as 5%. So when you have the cancer cohort, proband, a cancer proband, the probability will be higher than that. And this is the data from Genomic Thailand. This is Thai data is that if you have a case with positive clinical parameters, is that you have a cancer patient that fit the description of the Bethesda or the Amsterdam criteria, right? You have the family history, you have a gene. Lynch syndrome associated gene can be found up to 13%. So to identify the potential familial case is one of the attention that we have to give into the molecular testing. Now, we have to idea or to policy to do this. First is we test all, right? If you have a newly diagnosed colorectal case, this is the workflow is that we start to test with the DNA mismatch repair by immunohistochemistry is fine. Start with that first. And then if we found deficiency in MSH2, MSH6, or PMS2, then that is probably Lynch syndrome, and we can go to the germline testing right away. But if you have MLH1 deficient, it can be either the sporadic hypermethylation or the inherited disease. In that case, if you don't want to do the methylation assay, you can use BRAF assay testing, because if you have the BRAF mutation, it's quite associated with the sporadic MLH1 hypermethylation. Now, if you don't want to test everyone, because if you have the MSI high tumor, only 2 or 3%, that is a germline one. Most of them will still be sporadic. You can use the clinical criteria is that you select the case with high probability of being inherited disease, and then test some of those cases. These clinical criteria can be adapted based on your current practice, right? Like in the age group, you can choose 45, 60, 50. It depends. But if you use it depends on how prevalent that you have the inherited cancer gene in your population. If it is high, maybe it is better to just test everyone. If it is low, it might be more cost effective to test just some of them. Okay, for the second goal is that to specific mutation for targeted therapy. And because we don't have time for that, and many of you who attend this conference is the expert in the field, so I don't need to revise on the transcription pathway, but it is like it for the colorectal cancer. Previously, we grouped it into two groups broadly, is that it is the chromosomal instability pathway and the microsatellite instability pathway. Both have the sequential multi-step carcinogenesis, but but the set of gene that mutated is different. Right? So if we try to map it into the current consensus molecular subtype, the MSI high tumor will be a subset of the hypermutated or ultramutated CMS1 subgroup. This group has a lot of antigenic property, have a lot of neoantigen. So this one has a higher probability of response to immunotherapy. And the classical one is the chromosomal instability pathway. Those are the pathway that gain the mutation through the APC, KRAS, and TP53 sequences. So these two has a different set of mutations that are common in them. But the classical non-hypermutated one, we know that it is the KRAS, PIK3CA, and RAS. So these are the mutations in the MAP kinase pathway. While the ultramutated one has one mutation in the MAP kinase pathway in the BRAF, but this one we know that it is not quite effective to target this one. Even in this group, the vomurafenib is not quite responsive in this one. So that another thing is that we cannot use the molecular profile as the indication for given the medicine as a whole. You need to understand it and match it to the tumor type and the clinical situation. So here are the well-known and well-established mutation for the target therapy. We know about the RAS. This one is not the targeted one, but if you have the mutated RAS, it tells you that the patient will not be responsive to the anti-EGFR because this activation happened at the downstream in the activation cascade. For the BRAF, it's also downstream to the anti-EGFR, but in this context, we know that the BRAF mutation is associated with the sporadic MSI high. So this one will be more responsive to the chemotherapy, and most of the time, the decision will be not with the anti-EGFR, so it's less impactful. So for the HER2 or ERBB2 amplification, now we found it in around 2% of the colorectal cancer, and usually it's mutually exclusive to the RAS and RAF. That means if you have this one, you won't have mutation in this one. Dr. Mandy used the Heracles criteria, which is the pretty strict criteria to call the positive one. Okay, so many institutes use the My Pathway and Destiny criteria, and they claim that it had the similar response. But again, if you use the relapse criteria, you will include more patients that won't be respond to this one and increase the cost of the medication. So it depends on the local the clinical decision, reimbursement, the treatment option. So for the PIK3CA, you don't have quite an option yet, but there's some data that the patient with this one mutation may have the successful adjuvant response to acetylsalicylic acid. And for the NTRK one has gained a lot of interest in the past few years, right? When I was there in 2018, the FDA just approved the tumor type agnostic NTRK indication, and suddenly every people send the sample to us to do the NTRK, and the result is that it's not quite common in colon cancer. You less than 1% that you identify it. But if you found it, yeah, you can give the NTRK, anti-NTRK, and it might help patient in the metastatic disease. In the recent data, they found that the NTRK tumor seem to associate it with the MMR deficient. So in that case, you have two indications, right? You have MMR deficient, it might be the MSI. You might be able to use either the NTRK or the immunotherapy. So it depends on the clinical situation. Okay, for the last one is that right now, because the sequencing cost is cheaper and cheaper, and there are two main indications that we need to do the large scale testing. One of them is the TMB, but I will talk about the MSI first. The MSI high tumor, we can see it in around 15% of the sporadic CRC. we can interrogate it two ways. First, we look at the microsatellite itself. The standard to call high or low is depend on how deviate of the microsatellite loci to the normal one. So you can use either the mononucleotide panel or the NCI panel. Mononucleotide panel is a little bit more sensitive than the NCI panel. So, but right now, I think less and less doing the MSI test using this technique. They either do the NGS MSI testing or they put more emphasis on the ISC. Because this one, you can identify the defect protein, which imply the defected gene in one go. So, but there is some caveat that we have to be concerned. First, the MSIH may not occur in colorectal cancer of patient with the germline MSH6 mutation. So if you have MSH6 mutation alone, you will fall under the Lynch syndrome, but the MSI may not be high. So that one source of the discrepancy between the ISC and the microsatellite test. The second one is that some of the missense mutation will cause the non-functional protein, but the antigenic is retained. So in that case, you will have the retained immunohistochemistry signal, but you have the MSI high. And the last one, we know that the MLH promoter hypermethylation, this is the gene silencing. So you will see loss of MLH1 expression, but when you sequence it, you won't see the mutation in that one. You need to do the methylation profile. So for the tumor mutation burden, the definition is that it's the non-germline coding variant per million base pair. Because the definition is that you need to calculate it to the billion base pair. So the accuracy of the tumor mutation burden, you need to sequence a lot. And this is the profile of the microsatellite. Sorry, if the TMB is that each type of tumor will have a different average mutation burden. So if you have a lot of mutation burden that is somatic, non-silence, it creates the neoantigen that will stimulate the immune response. So with this logic, they say that if you have the tumor mutation burden high, the probability of response to immunotherapy will be higher. So for colorectal cancer, it falls into the intermediate one. So if you want to call the colorectal cancer a mutation burden high, that means you have to have a lot, quite a lot, because the colorectal cancer is the multi-step carcinogenesis. So you tend to have more mutation than the simple tumor, like the glioma, that quite a simple tumor, right? And many of the colorectal cancer has TP53, so you have the mutated phenotype, not to mention the MSI and the hypermutate one. So to use the tumor mutation burden, you need the full panel sequencing, and then you need to map it into the average of the mutation for each tumor type. So these are three main goals for the molecular diagnostic of the clinical aspect. And because all of these can be achieved in one CGP assay, right? So even in the night, when I was there, there's a lot of tendency to just do the solid tumor panel instead of doing each one by one, because it's more cost effective and effective. So I think in Thailand right now, it still depends on the reimbursement scheme too. If the government universal scheme, if they're limited to the single gene assay, that might be a role. But we have more and more people doing like this, is that it doesn't matter whether the case is what, we just do the full panel and we report only the one that they request. It might be easier to manage that way. Okay, that will be all from my side. Thank you.
Thank you so much. Pathologist, any question from you? Hello. If not,ขอเซอร์เจียนหน่อยได้ไหมคะอาจารย์อาร์ต Any question?
Yeah, that's very nice. Thanks to all the speakers. I think these are some of the informations are really interesting and updated. Glad that I attended this session because it's very informative and lots of updates for myself. And the only wish I think for all the surgeons would be particularly on rectal cancer pathology results report. We wish to have the same standard patterns of report from all pathologists in at least in our BDMS group, because nowadays there's still some challenges of variation that should be modified to the same pattern. So now I think today we understood of how important of pieces of information regarding to the clinicians and not only the surgeons but also the physicians involved in colorectal cancer treatment, because nowadays we do MDT discussion for each patient tailored treatments, right? So not only me, but the medical oncologists as well to move on as to aim for the best possible treatment and treatment outcomes. Thank you. That's only my comments. Thanks a lot.
Thank you. Ajahn pathologist, you hear the wish list of surgeon already,นะคะ. I think we reached the time. So sorry. So Prof. Lena, if you don't mind, if we have question later, we hope to put through the email to the speaker,ค่ะ. Is that okay?
Totally fine.
Actually, I'm a pathologist, and I have some points to share from my daily practice about polyp that Dr. Brian mentioned before. I found out that I wouldn't put the SM1, 2, 3 on the report because I don't know the thickness, the true thickness of the submucosal tissue, and for the formalin retraction artifacts, some of those factors I wouldn't be able to give the 1/3, 2/3 for SM1, SM2. So I'd like to share my point as a pathologist. If I have a carcinoma go through the way all down to the submucosal tissue, and sometimes you wouldn't have any residual intact nice layer of muscular mucosa to measure. So on that case, I would keep the extent, the two tumor thickness when the carcinoma destroy every microanatomy structure. I would give the thickness of the carcinoma that involved from the surface to the deepest point of invasion. And if there is a residual tubular adenoma that have the intact layer, that may give you some idea that the base of the crypt of adenomatous epithelium go down. The base of adenomatous epithelium would give you some idea that that place may be a muscularis mucosae starting there before, and I would give the depth from the base of adenomatous epithelium to the deepest point of carcinoma invasion. But I do mention in the report that in that case, I struggle with there is no intact muscularis mucosae. Sometimes they let you spray of muscularis mucosae plus desmoplastic fibromuscular reaction. So I just like to share my experience that it's not always possible to give a precise depth in a polypectomy specimen. So in that case, I just give the information about the tumor thickness, tumor depth, and the whole size of polyp and carcinoma, proportion of the carcinoma in the specimen, just to give more information as much as possible for surgeon to design their further treatment. And for I don't know if Dr. Brian put them for sessile polyp, if you put SM1, 2, 3 on the report and for pedunculated polyp, I do put a Hackett classification also because it's easier to appreciate the microanatomy for pedunculated polyp, but not a sessile polyp.
Yes, thanks. And we don't put the SM levels on there. It sounds like your reporting is even more detailed than what we standardly do, because that depth is such a controversial and actively researched area. So I think it's great to kind of do your best to give an indication. But that article highlights exactly what you're struggling with, and we have the same kind of issue too in our group. We don't have a good answer either. So
Dr. Tuff,
thanks for sharing
raise
that.
hand.
Sorry. Yeah. Actually, that my opinion is that actually the SM measurement is simple. It's not easy. The successful one is not for the pathologist. It's for the surgeon, right? It's just the measurement from one point to one point. The problem is that the sample is not good enough that we can identify those 2 points. So if you have been forced to do the SM measurement, the clinician who cut it for you need to give the best sample available, right? And you need to communicate with them. If they send the bad sample and ask to do the SM measurement, it's not possible. The measurement is simple. The measurement is simple. It's the sample that has the most issue.
Right, it's rare to sample the entire submucosa, so we just don't get that on our polypectomies typically.
Okay, any further question, please pop into email, naka, and we will send for you. Thank you very much for a very comprehensive from the 3 speakers talk today, and we wish you a good day ahead, ka. Thank you, ka.
Thank you so much, everyone. Have a good day.
Pleasure.
Okay, bye-bye. Thank you very much.
Bye.